Welcome to USA Health Claim Coach. My promise to you in every single explainer on this channel is simple. By the end of today's lesson, you will have a clear understanding of exactly what steps to take next with your health claim process. No confusion, no complicated insurance jargon, no uncertainty about forms, documents, or eligibility requirements. Just straightforward, easy-to-follow guidance designed to help you navigate health claims with confidence and peace of mind. Whether you are filing a new claim, appealing a denied claim, understanding your insurance benefits, or learning how to maximize your healthcare coverage, you are in the right place. Here at USA Health Claim Coach, our goal is to simplify the process, save you time, and empower you with the knowledge you need to make informed decisions about your healthcare claims. Today, we're breaking down how to master the UB04 claim form to prevent denials and stop revenue leakage. So gather your documents, get comfortable, and let's walk through today's lesson together, one clear step at a time. Let's get started.
Here's our roadmap for today. We'll start with institutional billing basics, move into the anatomy of the UB04, uncover the root causes of denials, navigate the upcoming fiscal year 2026 updates, and finally wrap up with denial prevention best practices. All right, Section 1, Institutional Billing Basics, the Foundations of Facility Claims. Let's start by clearing up a crucial difference between the two absolute titans of medical billing, the UB04 and the HCFA 1500. They might look kind of similar at a quick glance, but you absolutely cannot use them interchangeably. The UB04, also known as the CMS-1450, is explicitly designed for institutional, facility-based claims. We're talking hospitals, skilled nursing facilities, and hospices, and these are billed primarily to Medicare Part A. On the flip side, the HCFA 1500 is for your professional claims, capturing the services of individual physicians or groups, and billed to Medicare Part B. Mixing these two up, well, that's a fast track to a rejected claim. Now, you might be thinking to yourself, who even uses paper forms anymore? And you'd be right. Under the Administrative Simplification Compliance Act, Medicare actually prohibits paying out initial claims submitted on paper, unless you happen to meet some very, very specific exceptions. So, enter the 837I. That I stands for institutional. This is basically your digital equivalent to the paper UB04. It's a standard electronic format you've got to use to submit these claims efficiently and, more importantly, compliantly. Moving right along to Section 2, Anatomy of the UB04. Let's look at the danger zones. Take Form Locator 17, for instance. This is your patient status code. It's just a little 2-digit code, but it packs a massive punch because it tells payers exactly where the patient went right after discharge. This heavily impacts your diagnosis-related group or DRG payments, as well as Medicare's post-acute transfer policy. Think about it. If you report a code 01, which means discharge to home, but the patient was actually transferred to a skilled nursing facility, you are looking at a massive DRG payment error and a huge glaring audit risk. Accuracy here isn't just a suggestion, guys. It is literally mandatory. Another major danger zone, mismatched codes between Form Locator 42 and Form Locator 44. You absolutely must ensure your revenue codes align perfectly with your HCPCS, or healthcare procedure codes. Why? Because revenue codes explain the specific accommodation or ancillary charge, like, say, an ER visit. If the procedure described by your HCPCS code just doesn't make logical sense with the department mapped by your revenue code, your claim is going to suspend or just be denied outright. Alignment here is absolutely critical. This brings us to Section 3, Root Causes of Denials. Let's do a little denial autopsy. So, let's ask the multi-million-dollar question, shall we? Why exactly is Medicare bouncing these claims back to your billing department? What are the fundamental disconnects happening between your facility and the payer? Here are the top 5 culprits. First up, duplicate claims. This usually happens when an impatient biller hits resubmit before that agonizing 30-day processing window is actually up. Second, we've got bundled services. This is where you try to bill separately for a service that's already baked into a global fee. Third is sending the claim to the wrong payer, usually due to a mix-up with coordination of benefits. Fourth on the list is a lack of medical necessity, which almost always comes down to a missing advance beneficiary notice. And finally, number 5, billing for non-covered services without attaching the proper GY modifier. Let's zoom in on those Medicare secondary payer or MSP rules for a second. By law, you have got to figure out if Medicare is the primary payer before you ever submit the claim. If the patient is working-aged and under a group plan of more than 20 employees, that's a Type 12 MSP. If they were in an auto accident, that's a Type 14. Sending these claims to Medicare first when another entity is legally on the hook to pay guarantees a denial. And trust me, that severely slows down your cash flow. Also, please don't fall into the bundling trap. Medicare's National Correct Coding Initiative uses what are called medically unlikely edits, or MUEs, to automatically catch incorrect units of service and unbundled procedures. It's like a digital tripwire. For example, if a surgical procedure inherently includes an evaluation and management service the day after, and you try to bill for it separately, the system's edits will catch it immediately. You have to know the specific edits that apply to your codes. All right, let's look ahead to Section 4, Navigating Fiscal Year 2026 Updates, the Policy Horizon. According to the official MLN Matters release, upcoming changes to the inpatient prospective payment system and long-term care hospital payments will go into effect for hospital discharges occurring on or after October 1st, 2025. This means your software vendors, your clearinghouses, and your entire billing staff need to be completely aligned with these updates before the fall. The magic number for the upcoming year is 772. Based on the ICD-10 Medicare Code Editor updates, there will be exactly 772 Medicare Severity Diagnosis-Related Groups, or MSDRGs, for fiscal year 2026. This comes after 6 deletions and 5 new additions from the previous year. If your grouper logic isn't updated with these specific changes, well, your claims will fail validation instantly. No way around it. You'll also need to prep for a couple of major financial shifts. First up, CMS is placing a 5% cap on any decrease to a hospital's wage index from the previous year. That's designed to protect facilities from massive funding cliffs. Second, beware of strict payment reductions for replaced implanted devices. If a hospital replaces a device without cost to the patient, or even with a credit of 50% or more, your IPPS payment will be significantly reduced for specified MSDRGs. Let's wrap things up with Section 5, Denial Prevention Best Practices. This is your compliance playbook. I cannot stress this time frame enough. 1 calendar year. You have exactly 1 calendar year from the date of service to file your Medicare claims. If you miss this timely filing deadline, your claim is denied. And here's the real kicker. It cannot be appealed. It is a hard, absolute stop. So, what can we do? Here are the proactive steps your team absolutely must be taking. First, check your Medicare Administrative Contractor's Interactive Voice Response System, the MAX IVR, before submitting, just to verify primary payer status. Always ask patients for all their insurance cards. Some might have an Advantage plan, but still carry their original red, white, and blue card in their wallet. Secure those advanced beneficiary notices ahead of time. Meticulously cross-check provider NPIs, make sure your statement periods match your service dates, and always use your encoder software to scrub for medical necessity before you ever hit submit. Now look, if a claim does get denied, don't panic. But also, please don't just blindly hit resubmit. When performing a root cause analysis, you need to follow these exact steps. Step 1, investigate the exact reason code. Step 2, try to correct simple clerical errors, like a wrong NPI or a misstep date of service, directly through the MAX online portal. And Step 3, always wait the full 30 days before resubmitting. This ensures you don't accidentally trigger a duplicate claim denial. For those of you managing the IT side of things, setting up new electronic EDI systems requires a very specific testing phase. Remember, to become certified, you have to submit a test file of at least 25 claims, with a T in the ISA 15 segment. This just ensures you can successfully pass both Level 1 syntax edits and Level 2 Medicare business edits before you ever transmit live patient data. The American Institute of Healthcare Compliance states it perfectly. They say, accuracy must be the focus of documentation, coding, and billing compliance efforts. It's not just about speed, right? It's about getting it exactly right the first time to prevent waste, prevent abuse, and ultimately prevent lost revenue for your facility. So I'm going to leave you with this final thought to review with your billing team today. Are your current billing practices actively protecting your revenue, or are they putting it at risk? Because mastering the UB04 and staying ahead of these CMS updates is literally the absolute best defense your facility has. Thanks for joining me on this explainer. Keep those claims clean, stay focused, and I'll see you next time.